A 45-year-old farmer is brought to the emergency department with a concerning set of symptoms. He presents with neck stiffness, feeling generally unwell, and mild yellowish discoloration of his eyes, which suggests jaundice. The timeline is important here. He was apparently, just 1 week ago, when he first developed a flu-like illness. During this initial phase, he noticed reddish spots in his eyes, known as conjunctival suffusion. Although these symptoms settled over time, he now finds himself unable to perform his regular farm work due to persistent neck stiffness and generalized weakness. On physical examination, his temperature is elevated at 38.8 degrees Celsius. He has conjunctival icterus, which is the yellowish discoloration of the conjunctiva, indicating jaundice. Neurological examination confirms neck stiffness, raising concern for meningeal irritation. His blood tests are particularly revealing, showing deranged liver functions and acute kidney injury. This combination of hepatic and renal involvement is an important diagnostic clue. Interestingly, both imaging studies and lumbar puncture came back negative, meaning no bacteria were identified through routine testing. This biphasic illness with multi-organ involvement in a farmer, combined with negative routine tests, should immediately make us think of leptospirosis. Leptospira meningitis is caused by Leptospira interrogans, a spirochaete. The key feature of this infection is its zoonotic transmission. The primary reservoir is rodents, particularly rats, which shed the bacteria in their urine. Humans typically acquire the infection through contact with water or soil contaminated with infected animal urine. This explains why farmers, sewer workers, and people involved in water sports are at higher risk. The bacteria enter through cuts in the skin, mucous membranes, or even intact skin after prolonged water exposure. The pathogenesis occurs in distinct stages. First is the primary leptospiremia. During this phase, organisms circulate in the bloodstream and can invade various organs, including the central nervous system. Importantly, leptospira can be present in CSF during this stage, even though patients may not yet have meningeal symptoms. The second stage is the leptospiruric stage. During this immune phase, leptospira organisms are cleared from the blood, but persist in immunologically privileged sites like the kidneys and eyes. The bacteria are shed in urine and can still be present in CSF. The term aseptic literally means without infection, but this is actually a misnomer. Aseptic meningitis can be caused by infections, but specifically by viral infections and leptospirosis. The key distinguishing feature is that it's not caused by any pyogenic bacteria, which are the typical bacteria that cause purulent meningitis, such as Streptococcus pneumoniae, Neisseria meningitidis, or Haemophilus influenzae. The critical laboratory finding is that CSF culture will not show the presence of any routine bacteria causing meningitis. Standard bacterial cultures come back negative, which is why imaging and lumbar puncture in our case appeared negative on routine testing. This negative culture result, combined with the clinical picture, should prompt testing for leptospirosis. Aseptic meningitis is treated with penicillin. Laboratory diagnosis requires specific tests beyond routine bacterial cultures. Samples needed include both CSF and serum. Direct detection methods include dark ground microscopy, in which Leptospira appear as tightly coiled, motile spirochetes. Culture can be performed, but Leptospira is fastidious and requires special media, such as Fletcher medium. Growth is slow, often taking several weeks, so culture is not useful for immediate diagnosis. PCR, or polymerase chain reaction, provides rapid detection of leptospiral DNA and is increasingly available in reference laboratories. Indirect methods detect the host's antibody response. The microscopic agglutination test is considered the gold standard. It detects antibodies by mixing patient serum with live Leptospira organisms and observing agglutination under dark-field microscopy. IgM ELISA is more practical for routine diagnosis, detecting IgM antibodies which appear early in infection. A 32-year-old female presents to the ED with shortness of breath and weakness associated with chest tightness, congestion, hoarseness of voice, and difficulty swallowing. The difficulty swallowing, or dysphagia, is a critical warning sign of bulbar muscle involvement. A crucial piece of history emerges. She recently consumed canned tuna. This dietary history is extremely important for considering foodborne illnesses, particularly botulism. Initial investigations appear relatively reassuring. Biochemical and hematological tests are essentially normal, except for mildly decreased serum calcium at 7.9 mg per deciliter, which is just slightly below normal. MRI of the brain is also normal, ruling out structural lesions. However, her clinical course deteriorates rapidly. After just a few hours of admission, her breathing worsens significantly. This respiratory decline necessitates intubation, mechanical ventilation, and ICU admission. The rapid progression to respiratory failure is characteristic of severe botulism. A lumbar puncture is normal. Blood is sent for a crucial test, detection of botulinum toxin. This case highlights the rapid, life-threatening progression of botulism and the importance of considering it in patients with bulbar symptoms and a history of consuming preserved foods. Clostridium botulinum is a gram-positive bacillus. They produce spores. The key to understanding botulism outbreaks is knowing when these spores germinate. Spores germinate, and the bacteria become vegetative and produce toxin. The environment must be anaerobic. This explains why botulism is associated with improperly preserved foods. Home canned vegetables, preserved meats, and canned fish products can provide exactly these conditions if not properly processed. Commercial canning uses high pressure and temperature to destroy spores, but home canning, particularly of low-acid foods, may not achieve temperatures high enough to kill all spores. Once conditions become favorable in sealed containers, spores germinate, bacteria multiply, and most importantly, they produce the botulinum toxin. The virulence factor is the botulinum toxin, one of the most potent biological toxins known to science. An important characteristic is that the toxin is heat labile. This is why heating canned foods thoroughly before consumption can prevent botulism, even if spores are present. Now the mechanism of action. Once ingested, the toxin is absorbed through the gastrointestinal tract. It's carried by the bloodstream to peripheral nerve synapses throughout the body. At the neuromuscular junction, the toxin blocks the release of acetylcholine, the neurotransmitter responsible for muscle contraction. Without acetylcholine, nerve impulses cannot trigger muscle contraction, resulting in flaccid paralysis, where muscles become limp and weak. A particularly concerning feature is that once the toxin binds to the neuronal cell membrane, it's never released. The synapse is permanently blocked, and recovery requires the growth of new nerve terminals, which takes weeks to months. The toxin enters the nerve terminal and acts as a protease, meaning it's an enzyme that cleaves proteins. Specifically, it cleaves the snare proteins that are essential for vesicle fusion. These proteins include synaptobrevin, SNAP25, and syntaxin, depending on which toxin serotype is involved. When these snare proteins are cleaved, the synaptic vesicles cannot fuse with the cell membrane. As a result, acetylcholine cannot be released into the synaptic cleft. Without acetylcholine, the muscle fiber receives no signal to contract, leading to paralysis. The toxin affects all cholinergic synapses, but tends to affect cranial nerves first, causing the initial symptoms of blurred vision, difficulty swallowing, and speech problems, before progressing downward to affect trunk and limb muscles, and eventually, respiratory muscles. Foodborne botulism occurs when a person consumes food contaminated with preformed botulinum toxin. Common sources include improperly home-canned vegetables, fish products, and preserved meats, where the toxin was produced by bacteria growing in anaerobic conditions. After ingestion, the toxin, resistant to stomach acid and digestive enzymes, is absorbed primarily in the upper small intestine and enters the bloodstream. The toxin targets peripheral cholinergic nerve terminals at neuromuscular junctions. They bind to receptors on presynaptic nerve membranes, preventing acetylcholine release and blocking nerve transmission. Clinical symptoms follow a characteristic pattern. Initial symptoms include blurred vision, double vision, dry mouth, constipation, and abdominal pain. As more nerve terminals are affected, patients develop bilateral descending flaccid paralysis affecting peripheral muscles. Without treatment, respiratory muscle paralysis causes respiratory failure and death. Foodborne botulism. Classic presentation begins with blurred vision, diplopia, dry mouth, constipation, and abdominal pain. Disease progresses with characteristic bilateral descending flaccid paralysis, starting with cranial nerves affecting face and eyes, then moving downward to arms, trunk, legs, and finally respiratory muscles. Infant botulism affects infants under 1 year who ingest spores, commonly from honey. Unlike foodborne disease, spores germinate in the infant's gut, which lacks competitive flora, and produce toxin in situ. Presents with constipation, weak cry, poor feeding, and floppy baby syndrome. Generalized muscle weakness leading to potential respiratory arrest. Wound botulism occurs when spores contaminate wounds, common in injection drug users. Bacteria grow in necrotic tissue and produce toxin locally. Clinical features mirror foodborne botulism, but with longer incubation, is greater than or equal to 4 days, as bacteria must first proliferate. Laboratory diagnosis targets toxin detection or organism isolation depending on clinical form. In foodborne botulism, they detect toxin in implicated food, patient serum, feces, or gastric fluid. Testing food sources aids public health investigation. In infant botulism, they detect toxin in feces or serum, culture organism from stool, often more successful than toxin detection as bacteria actively colonize the gut. In case of wound botulism, they detect toxin in serum or wound samples, culture organism from necrotic tissue. Since they are obligate anaerobe, it requires enriched anaerobic media. Culture alone insufficient, organism must produce toxin. Mouse neutralization assay performed in reference laboratories. Suspected sample inoculated intraperitoneally into mice. 1 receives sample plus specific antitoxin. Control receives sample only. Survival of antitoxin-protected mouse while control dies, confirms botulinum toxin, and identifies specific toxin type. Treatment involves 3 main approaches. First, antimicrobial therapy with metronidazole or penicillin is administered. While antibiotics don't affect the toxin already produced, they kill any bacteria still producing toxin, particularly important in infant and wound botulism. Second, trivalent botulinum antitoxin is administered as early as possible. The antitoxin neutralizes circulating toxin that hasn't yet bound to nerve terminals, preventing further paralysis. However, it cannot reverse paralysis that's already occurred, as the toxin is irreversibly bound to nerve cells. Third, ventilatory support is often necessary, because respiratory muscle paralysis is the main cause of death in botulism.